everybody back. We're going to start. We got a great panel today. We've got George Crescent, Peter Ferries, Vishal Kapoor, who's going to be here shortly, Asma Kalik, Raj Malik, he's already here, and Eric Sisemsky is here as well from Beth Israel. So we're going to go to John Rundback. My name is Srini Tumala, and looks like we're going to do a common femoral artery intervention, or I think we may be doing the SFA. John, can you hear me?
SFA. I can. So as you go to front facing, great.
Hey,
Thank
John.
You so much, Srini. It sounds like we have a great panel. Can you hear me?
Yeah, I can hear you, John. It's Srini. How are you? Tell us what's happening.
Srini, how are you?
We've got a great panel
Good.
for you today, so we're interested in seeing your case.
Great. So you met our crew here earlier, Andre to my left, Lori and Diane. So really great to have them here once again doing our case of American Endovascular and Amputation Prevention in New Jersey. So this is a 78-year-old woman who has ischemic rest pain but no wounds in her right leg, no prior intervention. She underwent imaging, which showed she has a long SFA papillary occlusion. She's diabetic, hypertensive, dyslipidemia, prior smoker. She has a history of coronary artery disease as well. Her renal function is normal. So if we can, she's on a fully appropriate medication. So if we can go to input one, I'll show you what we've done so far. Good. So with ultrasound guidance, we got left femoral abscess, as you can see here, and that was very straightforward. And we were able to bring up a flush catheter and hook over the aortic bifurcation. You see here in advance. In this case, this was a 035 wide wire advantage wire on the contralateral side. Once we did that, we got some pictures here. I think you can all very nicely appreciate that flush CTO, not quite osteal CTO of the SFA. Can't quite appreciate the level of calcium which we saw in ultrasound. And obviously the ultrasound and IVUS are going to be much more sensitive to calcium. CT and much more sensitive to calcium than the fluoro. So in standard form, we gave it a shot. Well, we took some more pictures, so let's get the rest of this. So this is just all collaterals over here. Profundal collaterals coming down. None of these are sort of named vessels. You can see more collaterals reconstituting maybe popliteal island or just funicular branches, but you can see we reconstitute eventually single vessel perineal artery runoff. We'll take a look at that in a couple of obliques to try to characterize it a little bit better. And that one's not great because we have overlay on the bone. Here's a little bit lower. There's that single vessel perineal runoff, which starts to reconstitute through the communicating branch into that posterior tibial. And then, although sluggish, the posterior tibial artery is patent through the common plantar segment into the medial lateral plantar artery and into the foot. So our goal here is obviously a very long femoral popliteal revascularization.
Yeah, it looks like a tough case. And what's the indication again, John? It was rest pain?
Yeah, she's waking up every night. So this is a view where we get ipsilateral anterior oblique. What we're trying to do is identify where that perineal is adjacent to the bone, because this is going to be a retrograde perineal access, and you'll see in a minute. I don't know if it's saved, but hopefully I did. I tried to get intraluminally antegrade, and we couldn't. So it just sort of buckled. I guess I didn't save that. I apologize. So you're going to see a couple of runs here where we sort of first get the needle in, which is just a 21 gauge micropuncture needle, kind of get it in proximity where we think it is, and then we just start doing these puffs. As you can see, I'm sure you've all seen this experience in Germany. So I'm a little bit off, so we're going to redirect that, and now I think we're coaxially aligned with that perineal. There's going to be some nice teaching points as we get into this, so we sort of bring it down. And it's nice when there's dense calcium to see. In this case, the calcium is not easily seen. There's segments of calcium, but not where we want to get. And a key to this is you have to enter the artery about 30 to 45 degrees off the vertical, so that when you put devices in, you'll shear the access site. We've had that happen. And you're going to see a couple of these here now where at one point we sort of get some blood back. And again, you'll sort of keep seeing puffing as we do it. Some blood back, and now we're kind of aligned on it. And when we get blood back, we try to go with the wire. Initially, it doesn't go, so we Secret here, you can see here, we're not too bad. We're actually kind of on top of it here. So the secret here is to go to the opposite oblique and do a run and sort of see where you are. And you can see that we're deep to the vessel at that point. And then when we pull back, and you kind of missed it because I'm alternating between runs, and we're able to get our 018 command wire. And that actually got very easily. We trained out for a 2.6 CX9 microcatheter. And you can see in a knuckle wire configuration, it's gone very easily so far. Up the long occluded segment. And we'll see what Ivan says, but obviously when I see this, I'm a little worried that there may be a thrombotic component to this, right? Although she has a chronic presentation. That often a chronic disease has some thrombus in it. So this is a little embarrassing. We made a couple of attempts here with the ONA wire into our contralaterally introduced non-taper angle to get it, and so far we've been unsuccessful. We just switched out to the 014 wire. We'll give it a quick try, but otherwise, I'm pretty sure I should be able to direct this wire up to the sheath and then do mother and daughter sheath technique to get the wire out for our through and through. So this is what we're up to now. Any questions about that?
No, I think that's great, and I think your point about being careful with perineal artery access, you can definitely shear or tear that artery if you're not careful, and that's something to be cognizant of. Does any of the panelists have any comments regarding the approach here?
Yeah, I think the one thing that I heard that's really important too is when you are going through something that long and complicated, and it's going that easy, and you've got the history that's been given, that you do need to at least have in the back of your mind the possibility that you've gone through some thrombus. So that's an important point that Dr. Rundback pointed out.
John, how proximal were you on the perineal when you accessed it?
Mid-perineal. It was mid-perineal. Yeah, we wanted to have obviously a little bit of working room to go.
You say how?
Yeah, how high?
This should be easy stuff.
Any caution, any suggestions to the group about accessing there versus more distal, or what you run into?
Well, I think wherever the vessel is good, quite honestly, wherever I would have seen some good calcium to the target would have been my choice. So I wouldn't have to keep puffing, come up a little higher maybe. I wouldn't have to keep puffing contrast. But I think, mid to distal third is fine. Again, you want to have some working room as we do this. It's a little frustrating, so we kind of keep hitting it here.
Great. So we have Vishal Kapoor, who just joined us. He was just in that live case and got here. But Vishal, we have a patient here with a long segment SFA and popliteal artery CTO with a single vessel perineal artery runoff. Looks like it reconstitutes, I think, the posterior tibial artery, which is then the main vessel below the ankle. What's been your experience with perineal artery access when you have a single vessel in terms of how do you choose where to access it? What has been your guys' algorithm?
Well, I guess, if it's a CLI and that's the only artery and that's the only access, then of course you have to do a perineal artery access. I guess we do a combination of both fluoroscopy as well as ultrasound. If you have a good ultrasound tech, that really helps you, especially you want to cause minimal trauma to the vessel. But from a fluoroscopy standpoint, we just pretty much want to invert our feet in there, go a little bit of ipsilateral 30 to actually open up your intraosseous membrane where your perineal is, and the V shape that forms between the tib and the fib is where you want to really enter your perineal. And primarily, if you'll see us, we usually want to keep the access at the lowest caliber as possible. So maybe you just go sheathless, unless we're trying to do everything from below, which is very, very less likely. You would want to keep it sheathless. We use a microcatheter and a wire, and like he's doing, trying to cross over, marry it at the top, and then work from top down. So makes life easy, and especially keep the runoff as patent as possible.
No, that's great. Looks like looks like you're externalizing your wire there, John. So what we'll probably do just to get things yeah.
I don't know what this is going to look like until I do this. So I actually telescope the 035 over the 014 catheter, and I'm going to take the back end of a Viper wire now up and through to go and exteriorize it so it's appropriately directed. And then with that Viper wire, I can do any intervention I might need to do based upon the IVUS. So the first key, of course, is bringing the 035 and telescoping it over that 014 retrograde catheter so that we can easily now make the wire exchange. Back and replay that IVUS, and I will simultaneously go back to...
You're back live with us, John. So.
Yeah, great. Can you hear me?
Yeah, we can hear you perfect.
Can you hear me?
Yes.
Okay,
yes.
Beginning of that run? So this we did the IBIS. All right. Okay, I want you to go ahead and play that. So you can see here we simultaneously did a pullback and IBIS. We did some measurements. The perineal is about 3.5, and the SFA is 5, and then 6. And interestingly, a couple of things. I mean, first of all, I think we all agree with interluminal here. Second of all, I thought there was going to be a lot more calcium. At the time coming in was that we were going to do orbital atherectomy. And third of all, I see those kind of low level echoes, plus the way we cross makes me wonder if there's not some, thrombotic material in this as well. So, based upon that, I think we're going to sort of change our plan and not do orbital atherectomy. And instead, I've gone ahead and taken out the Orion laser from Angiodynamics. Eximo. This is a unique laser, 355 nanometer wavelength. It's got a 10 nanosecond pulse width. It's very effective against a wide range of plaque morphology. It was dense calcium, I think. Orbital isn't the way to go, but I think I love your interpretation of this. There does not seem to be a lot of calcium with plaque there. So we can go to.
That's great, John. I'm gonna, if you don't mind, I'm gonna ask the panel kind of what their thoughts are in terms of therapy at this point based on the IVUS. Maybe we can start at the end with Ozma. Yes, welcome.
Sorry, running a little late. So, you can hear me? Yeah. So, based on the fact that I'm sorry, I missed the angiogram, but just based on the
so it's a long segment SFA pop CTO with a maybe a distal reconstitution below the knee, but definitely a single vessel perineal artery runoff. And I believe it was rest pain. If John can chime in.
Sure.
Yeah.
Sure. And are we using a filter?
No filter yet. He just crossed and has did IVUS. That's it.
Okay.
Yeah.
Yeah, I mean, I would say,
first of all, it'd be hard to place a filter, right?
I typically have moved on to using more CSI, but I also do use a fair bit of laser. So like 172 or peripheral laser. And I definitely, given the fact that there's single vessel runoff, I would definitely put some sort of filter device for distal protection.
Yeah, and I didn't know if you saw the IVUS. It looks like it's mostly chronic disease with a little bit of maybe some soft plaque and thrombus in there.
So in which case, I would lean more towards CSI.
Okay. Vishal, what do you think?
So in this case, I guess laser is definitely a good option. But I mean, for me, I'm not in this probably lesion orbital atherectomy. I would probably be more leaning towards a directional atherectomy part if possible, because that can give you a little bit more control, see where a plaque is, and hopefully distal embolization. Even everybody claims they don't have it, but the chances decrease. So I would lean either laser or directional atherectomy in this case.
And would you put a distal protection device?
Preferably, yes. I mean, if it's just one vessel runoff, perineal, and peritoneal is pretty much like a profunda of the lower extremity. If given an option, definitely a filter is always a good option here.
Rajesh, what are your thoughts?
Sorry, I agree with Vishal. I'm a big directional atherectomy user. I think it's suitable anatomy to use that, and then followed probably by DCB, and then potentially some spot stenting because of this really long lesion that you have. I mean, there's probably going to be some mode of failure. If things are easy to track up and over, then I would probably lose the access from below, unless you need it for flossing and to push things up. It looks like things are pushing through fairly easily. Then, probably a filter would be a good idea. Although I can't remember the last time I've used a filter. It's been quite some time. I mean, I know when we trained, we used to say, single vessel runoff. Again, if you're concerned about, fresh clot or something, that's a different story. But I haven't used a filter in a while, and maybe I've just gotten lucky. But you have to be careful, though. That's no doubt.
Eric?
Yeah, I think those are all reasons I use a lot of orbital atherectomy. The IVUS, there were some periods where I was concerned that there was sub and then re-entry, and I couldn't tell. We were moving a little bit quickly through them. I don't know if you saw that. And just being mindful of that when you're going to take an aggressive atherectomy device in the subminimal space. Some people feel very comfortable with it. Some people have different experiences. This is a lesion that I'm assuming is going to require some reasonable amount of stenting. And you have a nice nub at the proximal SFA to land something before the profunda. So, I'm a little less concerned about some of the lesion prep here because I'm probably going to use a stent. But I think this is a reasonable approach.
George?
Yeah, I would. I like to use laser. The IVUS, I think, showed a lot of soft and a lot of chronic stuff, not a lot of calcium. It wasn't terribly eccentric. So staying in the center with something that's going to debulk in a way to where you can get that range from 3.5 all the way up there's sometimes a little bit of a problem taking really aggressive devices down into the perineal just because it's not a very big artery and it's your only one. And I would use a filter. And the only other caveat would be if, like on the IBIS, I think there was a couple areas that looked a little bit suspicious. And if you're ever even thinking about thrombus, there's nothing wrong with taking some sort of thrombectomy catheter down through that and see what happens. Sometimes it opens up a 2 millimeter channel and turns out that you had kind of an acute on-chronic event.
And I think, John, you're using the Orion laser by Angiodynamics here. Can you tell us what size catheter? Are you using a 2.0 with aspiration or the 1.5, which is kind of known as more of a workhorse?
Yes, I've been listening, to this conversation. So, we also, if I was in a hospital, then, we probably would have gone ahead and maybe considered some penumbra here or something like that. But what we have in the OBL is the 2.0 and the 2.35 Orion have aspiration. So they have some thrombectomy component to it. It's really good in mixed morphology. And you also were flushing through the sheath. We have a wire clamp at our exit site that's super, super, super slow. Regarding distal protection, great protection option here. I'm not sure where we're put protection. I'd have to lose that perineal access potentially to do that. Plus, to be talking in that single vessel perineal. There is the wire on, from CSI, and that's a good one, which would have been potentially an option. We do have that. Another thing you do, of course, is for the sheath and have retrograde access and aspirate. But the data with this particular laser has been really quite good as I take it out with regard to very low embolization rates. And you'll notice that I kind of did most of it, but I didn't entirely come through that distal cap, which is obviously a strategy that many of us like. So,
yeah,
a single pass of 50 millijoules.
So you're going to do
that's attractive.
So you're going to do the classic 2 passes with this laser, John?
Well, it's interesting. I was the national PI on the trial, and they didn't recommend 2 passes. At that time, people were doing 2 passes, but not clear. We're going to be doing a cadaver study looking at just that to optimize it. That's a single pass of 50. So I think we're also well on our way.
And can you tell us, John, why you chose 50 instead of 60? And obviously, single pass is what's recommended.
Yeah, that's the IP. We start with 50. That's the guidance. If it's dense calcium where you're going to get hung up, I'll switch to 60. And some people like to do the 2 passes, 50 and 60. But I think that probably we had some cap here, and which I couldn't cross. I really tried, and then wish you'd seen how my wire was buckling, and then a lot of hibernated vessel, right? Because this looks really good. The other thing is we have some data presented at Viva in 2019, I believe it was, showing that, this obviously needs to be developed more, but with or without DCB, latency is about the same with this laser. So we're going to do some additional studies with the company to see if it maybe because of apoptotic cell death or some inflammatory cell death. So that's
It's pretty remarkable what you have there with just 1 pass with that 2.0 catheter with aspiration. Pretty impressive.
Mm-hmm.
And you're right. If you have a single, go ahead, John.
Is knowing, what do we do next?
Yeah.
It looks really, really,
that's
really
the question.
We'll take down our IBIS again, obviously, and I don't think we're going to need to scaffold this whole thing. That's the way it's looking. Low risk. I suspect that we'll just have to do something on the bottom.
And I think for everybody watching, John brought up a good point. He's like, he could put a sheath in his original perineal artery access as a protection, but now you're upsizing, you're putting a sheath in, single vessel, you got a high access. Remember, the more proximal you come with your pedal access, the larger those compartments and the more likely you are to get a compartment syndrome and bleeding and so forth if you have a problem. So you obviously, I think most of us would do probably a catheter and wire technique like you did here. I think anybody on the panel would do anything different. Yeah.
It looks very impressive by just doing a laser with a lot of hibernating.
I think I'm happily confused here. Right? I mean, this looked like for the world is going to be super impossible. And, so far, obviously, we've kind of miscalculated the lesion morphology, which is another nice thing about this round laser. It's really good. I mean, their results in ISR, in moderate calcium, mild and moderate calcium, in fibrocalcific plaque and soft plaque are essentially equivalent, 87% primary patency of the year, more or less. So it's sort of a good tool when you have this mixed morphology situation or some uncertainty about what the plaque morphology might be.
John, do you want us to, are you going to do IVUS now? Do you want us to go to one more talk and then come back to you, or
sure,
what do you think?
Go to a talk, I'm going to do IVUS and then see if I can make more sense of this.
So has everybody been watching so far in terms of this case? What are your guys' thoughts after the initial laser in terms of the luminal gain that was achieved?
Let's say that Rundback.
Ozma, what are your thoughts on that?
No, I mean, I was actually
Can you hear me, guys? We're going to play back
pleasantly surprised to see
the IVUS
just
after.
one pass, like Vishal mentioned. It could have been just a hibernating vessel. I also think sometimes when there's such a drastic luminal gain, I also wonder sometimes how much of this is like acute thrombus and whatnot, because it was quite impressive. And I think with IVUS we can, talk about more definitive therapy, sizing of DCBs. And I also wanted to ask the panel, so what about that proximal ostial SFA? How does everybody treat that? Do you guys just use a dedicated drug-coated stent, or versus, what do you guys do?
Vishal, what do you guys? What's your? We see your live cases every month, so we kind of have an idea. But what?
No, I mean, we usually try to assess the lesion. Like in this case, I mean, you do a pre-dilatation with the balloon, see how the response is. If you see a lot of dissection and you're going to stent it anyways, then we would probably go for a drug-coated stent. But if you think the luminal gain is great and we don't have much of dissection plane, then we believe in a concept of nothing left behind. So we'll probably do a DCB and see how it responds. Worst case, you can put in a bare metal stent over a DCB so that you just make sure whatever hard work you did, at least the inflow is established. But in this case, I mean, it's a very impressive run after the luminal gain after the laser. So I think, I'm sure they have a strategy in mind, but I would probably just drug code all the way and see how you respond. And like Rod said, maybe do spot splinting if need be.
Yeah, I think everybody's leaning towards POBA, DCB in this case. Spot stenting is necessary. Anybody have any other options that they would consider here? Obviously, nobody wants to put in a covered stent here with a single vessel runoff. Terrible patency rate. You also have a CTO that's at least 25 centimeters long, which is another, bad marker for that as well. John, what do you want to update us on where you are and what your thoughts are for therapy at this point?
Yeah, so I think you saw the IVUS plane there. And this is sort of part of the problems with IVUS and long lesions is that obviously there's a lot of residual disease. We were going to make a second pass at 60, but the device kind of left to freedom. So we didn't open a second device. So what we did is we came down with a balloon. It's a 3 millimeter balloon based upon our IVUS sizing. We pulled the retrograde perineal access to the balloon hemostasis here. So we're going to get this picture. And then, I don't know if you appreciate on the IVUS, and certainly the feel we had crossing is that there is osteally and proximally some real firm plaque. So my gut is that will need scaffold up there. I'm not sure that scaffold the rest of it. We can just do DCB. The only thing is, we have some data suggesting that DCB doesn't add much. And there's still a lot, if you look at IVUS, there's still a lot of tissue between the lumen and the media. So I'm not 100% confident that DCB will be the best way to go.
Maybe I can ask, I think Rajesh and maybe Eric, somebody was talking about directional atherectomy for a long segment CTO such as this. Do you find that it's time consuming? Do you think it takes, how long would it take you, Vishal, Rajesh, or if you were doing directional atherectomy on something like this? Because I know you guys had mentioned it in this case.
Yeah, I mean, of course, it does take time. You have to take a bunch of passes, clean it out. So you're probably talking about 15 minutes or so, 10, 15 minutes of just multiple passes going through the whole thing. What do you think, Michelle?
No, I agree.
30 degrees oblique.
Yeah, it's like depending, you want to take time early on, or otherwise you're chasing a deadline, taking time later on. So I guess in my case, I'll probably be upfront and do directional atherectomy. It takes time, but if you do it the right way, then the luminal gain and the IVUS probably shows better.
And if you're doing directional atherectomy, would you definitely put in a distal protection device in this case? In your guys'
in this case, yeah, with wind muscle runoff, we always want to be sure. Like I said, people say there is no distal embolization. It's not true. I mean, you'll find some. I mean, I know Raj doesn't believe in filters.
I do believe it. It's just been a while. But I mean, as far as directional atherectomy, points where like the SFA osteum, I'll spend some extra time there. Maybe the popliteal, like things where I don't want to place a stent, or I mean, you can use persipara and stuff, but again, single vessel runoff. So areas that I don't really want to put a stent, I'll probably spend some extra time and do a nice job. I think in the middle, you can probably, be a little bit more quick because,
I think one place we've used it a lot is when we've found focal dissections or dissection flaps. Just basically cutting that flap out has been really beneficial in terms of trying to prevent placing a scaffold of some type. It sounds like John is not leaning towards
so we're
DCB.
Do balloon angioplasty at the ostium here, and see what the waste is on that balloon. Get a sense of what we're doing. You can see the calcium right at the ostium, which is where we had our initial trouble crossing. You just saw also, you saw that last angiogram with excellent balloon hemostasis at our perineal puncture site. That's been removed. There's our balloon. So we'll just pop and see where we need to put this. So this is a 6 millimeter balloon. I think this is a jade balloon. What are we using? 6150 jade balloon. Okay. We're going to go ahead and dilate the ostium here. And I think this is going to be the problem area based upon the IVUS and based upon our haptics as we sort of cross this. And our plan then is to put a scaffold here. And I'm leaning towards the biomimics stent to the ostium, then we'll see what's left and how we're doing. And I don't know if you saw the last run, but in the upper portion of the perineal, there also seem to be an IVUS and angio residual stenosis, so we may need something down there as well. So this may be a top and bottom. Unfortunately, it's going to be impossible to treat the full segment of this. While DCB is good, you're talking about 45 centimeters of DCB, if that, probably longer. So I don't know how the panel sort of feels about that, but that's an obvious limitation. Again, we are on the OBL as well, so to be perfectly candid, it's not a super appealing. And you can see that, at this level at least, that's just what we felt when coursing. This is real disease. What's that, 2? Go to 4. So we're going to go ahead and balloon that. Yep, don't move. And then we're going to put the mimic stent there, and then we'll reassess at that point. And hopefully find something distally completed. And we understand that we're leaving residual disease. Even when we do DCB, we're going to be leaving residual disease. And I'm a believer in DCB, but not in this case. Not when it's 45 centimeters with a large amount of residual thrombus. Very unlikely to get good penetration out to the media. Data we have 6 with the laser, that it may or may not require DCB. So that's first line therapy.
What size balloon do you have, John, right now?
This is 6 millimeter based on the IVUS. Looks big, but that's what the IVUS showed.
Yep.
It does look a little bit big.
I think, just kind of carrying on from our FemPop CTO talk, it just shows you that sometimes you can cross these things so quickly and easily, but then delivering therapy after that requires really a lot of thought. And it's really tough to become algorithmic on what your therapy should be because there's a lot of nuances for all these cases. I mean, obviously, once you put in the stent, the clock starts ticking for ISR at some point. You're going to get it, and then you got to fight that battle another day. If you do just POBA, you don't have the patency rates that you need, obviously. And if you do DCB, you do great for about a year, and then you have some other issues. But it just shows you that, we have a lot of tools, but there's not a lot of data on kind of how we should do things.
Another nice, part of this case is the use of IVUS. It's dictating both your atherectomy choice, your sizing of your devices. It's a quick run, so I think we don't use enough of it, and we should probably use it more, and this is a good reason why in this case.
And I think in the coronaries, if you didn't use IVUS or something like that, people would be like, have you lost your mind, right?
You're shamed out of the lab.
For the cardiologists, for the ICs, they'd be like, what are you doing? And in the periphery, we tend to be a little bit more cavalier sometimes. We've gone to using IVUS pretty much as possible now because of all the benefits and the fact that it really does change therapy, as we saw in the earlier cases today. it's obviously showing us again how it helps this.
The hardest part with IVUS is walking away from things that don't look great, and you just have to accept them. And I think we do it all the time on angiograms, but we pick up more on IVUS. But once you get comfortable with that, it changes a lot of your approach for these type of disease.
Yeah, I guess, but the issue, like how we cardiologists ask the same question is, do we overdo things if we start doing an IVUS? We have to find a common ground. Angiographically, let's say there's no phlebital dissection, but the IVUS shows that your flap is just moving all over the place, and now we are stenting up, down, and now we have a metal jacket at the end of the day. Yeah. So now the patency rate is dipping down, and it defeats the whole purpose where we started from. So I guess...
No, that's a great point. Great point. And how many times do we hear, well, that it's a non-flow limiting dissection? And then you look with IVUS and it's a 70% stenosis, or it's fenestrated. There's multiple flaps. So, what do we do with that information is definitely true. It looks like, what kind of stent are you putting in, John? I assume it looks like a...
Let's say a biomimic stent. Obviously it's got this 3D flow swirling design. They've got pretty impressive data. They're above 80% primary patency out to a year. Average lesion length is 12 centimeters. So, let's see. Obviously a third generation stent, biomimetic stent. Let's see how that looks. And let's dilate. Let's balloon in.
And how high were you trying to? How high were you trying to come, John? Just to the origin in the SFA, a little bit above?
Yeah, a little above. I think the mistake that certainly younger operators make is they try to land it perfectly flush, and then you get geographic miss as it normalizes. So I ideally want to get a third to half the way up the mouth of the profunda. So I think just for the way it's sitting that we accomplish that. Yeah. You're going to see in a minute if I do post dilators first.
I think it goes back to what we were talking about this morning, that a lot of CFA disease extends into the profunda and proximal SFA. And, kind of like the old days of the renal artery stent, when you had aortic disease extending into the renal, you protruded about 1 millimeter or so in. Kind of the same concept here. And I think, over the years, we haven't seen too many problems with the profunda occluding. What's been your experience here on the panel in terms of stenting SFA?
Yeah, I mean, unless you have a really, really, really diseased osteal profunda, I find that it's pretty hard to jail it to the point where you're limiting flow. And it's certainly something that's, for the most part, pretty easy to rescue. Yeah.
I agree. I mean, I think, obviously, it depends on where your profunda is taking off and what kind of disease. This is a fairly healthy looking profunda, so common femoral artery too.
I think that's the caveat: a normal, healthy-looking ostium in origin, proximal profunda.
But I do think, not that it's necessarily relevant to the case we're watching, but to the topic of the session, that when you're thinking about the common femoral and interventions, I think you have to think of it a lot like we think of coronary bifurcations. Is it a 1-0-0? Is it a 1-1-1? Is it a 1-0-1? Because, contrary to what some people think, and I don't think anyone on this panel or this room necessarily would think it, but losing a profunda is not a benign situation. Yeah. So, sometimes when you're thinking about stent versus surgery, I think the anatomy of the bifurcation is really important.
Yeah, I agree with that. And again, when your stent goes down and you're extending across the profunda, that's got bigger implications than if you have some residual disease at the ostium. And so when I do common femorals, I usually do, some sort of either directional or shockwave and DCB. Try not to put a scaffold down for that reason.
Yeah, I don't mind the osteal scaffold in this particular case. I mean, obviously anything can reduce the nose, but you keep a short segment scaffold with the ostium. We tend to have a lot of that plaque burden. I think it might be better than leaving a lot of residual plaque unsupported. So,
it looks great. Looks great, John.
So we're going to sort of follow that down. I think let's do some more runs. My sense was, and we can do IVUS again. The problem doing IVUS is you're going to see a lot of disease, right? We already know that. We've already done it. But that there was something that was more notable distally. So I'm going to take a look for that and see if that needs any targeted treatment. This segment here looks really super, right?
Mm-hmm. So, John, how did you determine the length of the stent you put in just now? Just all based on IVUS?
It's based on IVUS, and I was about 7 centimeters down that nubbin where I started to form a loop and get subintimal. So I knew where I had probed at it, and so it's 100, I think. Looks pretty good. Yeah, look, there's a little bit of residual disease there, but honestly, I'm hesitant to go back and dilate that. I mean, as you have all seen, you get these cases that look good. There's maybe a little residual thrombus. You dilate it and then it occludes. So I'm sure we've all sort of seen that, and it's a little bit frustrating. So I have really good flow here. My gut is to, stop. And, I was just actually at AMP EU and talking to Marion Broadbent. I really adopted the European approach in cases like this. I would put this patient on enoxaparin for a month.
So, John, we had a question from the panel that there were still a lot of collaterals showing up in the in the thigh. Do you think there's maybe that lesion you were talking about is more significant than we think, or something else?
Towards you. Okay. I didn't appreciate that. I saw normal branching. I can't say that I thought there were a huge number of collaterals. We can go back and take a look at it. I mean, actually, I say that because I was actually noting that even though there's a lot of disease, radiolitis, all the kind of normal branching patterns seem to be pretty well preserved. Which struck me. Don't move.
What's your plan for post-intervention therapy at this point, John? Are we talking DAPT? Are we talking Compass?
There, which we have to touch up. But I think at this point, obviously we're big believers in the Compass and Voyager trial. Almost all of our patients, particularly a patient like this with polyvascular disease, there's a compelling case to using River 2.5 and aspirin. That being said, I'm going to start in this case and try to put it on low molecular weight heparin because, again, we want to get an acute result. And it's anecdotal. There is one study which shows you get lower rates of acute thrombosis in the first 30 days. And again, it's something I've kind of learned from our European colleagues a little bit. Let's see if we can oblique towards you. I want to get this off the bone. This is the one remaining segment that I'm concerned about.
Yeah. Asma, what are your thoughts on post-intervention therapy here? What do you think?
Towards me.
I have actually started using in the last couple of years. Just based on Compass and now based on Voyager PAD as well. I have started using the modified triple therapy where I would put them on aspirin Plavix, but I would also add the low dose Xarelto 2.5 BID. Not necessarily. I mean, I guess in this case maybe because there's just single vessel runoff. But also when I put a lot of stent. Also when I encounter a lot of thrombus, either pre or during the case. It's definitely for all the ISRs that come back because they usually, especially if they come back sooner, then
Let's get the assumption
that there's more thrombus.
And are you doing that right away, or are you waiting a week, a month in terms of adding it, or are you adding a triple therapy right away?
The modified triple therapy, that's why I said because I honestly don't think it's enough. I guess there is some potential risk versus not using it at all, but I am adding it for certain people, especially the high risk ones.
And Dr. Olin gave a great talk this morning about how there's, these tibials have a lot more thrombus than we think. It's chronic, but that's the mechanism, rather than above the knee. What about Eric? What are your thoughts? We talked about this earlier today in terms of medical management. Do you believe in this modified triple therapy approach? Should we do something else?
If you look at Voyager PAD, the problem with the modified triple therapy approach, or however you want to term that, is the bleeding rate started to become quite disproportionate to the ischemic benefit. And so probably the best bang for your buck is going to be either sticking on DAPT and switching to 2.5 milligrams of Xarelto when you feel comfortable a month to 3 months, or just doing it up front, which is really what Voyager PAD was designed to do. And so, I have patients where I've put them on up front, or I've had them on it already prior to intervention and continued that without clopidogrel after a peripheral vascular intervention. Rarely I'll do triple therapy. I've done it. My surgical colleagues are using a lot more full dose anticoagulation, to John's point, particularly when they are instrumenting, either surgically instrumenting the vessel or some sort of hybrid revascularization strategy. Again, our bleeding rates are a little bit higher than I would like. So I without more evidence, I'd rather just do aspirin and 2.5 milligrams twice a day.
That's where we're going on the venous side when you're doing these extensive reconstructions. There's a lot of inflammation that we're creating. So, who knows? We need data, right? Vishal, what are you guys doing at Mount Sinai now?
No, I guess with these high-risk cases, we definitely believe in adding the Xarelto to 2.5 BID for sure. But again, like you said, it's the mechanism of action or the failure is what defines how it is. If there is a patient coming in, especially with repeat intervention or ISR, then we are super aggressive and actually put them on full dose Xarelto for at least a month and then taper down into 2.5 because with the amount of thrombus present and their chances of having recurrent symptoms and CLI. So we are aggressive enough in our medical management strategy, of course.
George, Raj, anything different?
Yeah, same thing. I mean, even for the surgery, for the open cases, we've gone to using Xarelto 2.5. If I was just going to put them on dual antiplatelet, I now switch to just 2.5. Obviously, there's some patients that require full therapeutic dose, but for the ones that have a vein bypass, you probably just think dual antiplatelet's okay. I've switched my algorithm a little bit.
It just shows you how much we don't know still, right, about the best medical care.
Yeah, the only thing I would say is the wild card is as a lot of the patients, cardiologists too, I also think about multi-bed disease.
Yep.
So I've probably already treated them for some sort of coronary problem.
Absolutely, yeah.
And maybe something else. So the people who have really a bulk of multi-bed disease, I think my threshold to go to the Xarelto is very, very low.
Did you see Dr. Olin's talk? I mean, that's straight out of his talk. Too. That's great.
So John, how much Lovenox are you going to put him on? Or put her on?
It's BID. Yeah, so only 1 milligram per 1 milligram per kilogram weight-based BID.
Okay.
Are you going to do that for a month, John? How long are you going to keep him on Lovenox, your patient?
1 month, and we'll probably give ASA 81 as well. Again, that's sort of the European approach, and there's a factor study which did that as well.
Okay.
And then after that, if everything looks good on imaging, we'll switch over to River 2.5 on the extra. Now, I think this one segment doesn't look good, so I'm actually opted to put some tax down here. After the inflow we've treated, the whole vesicular conduit looks good, but right below this, once upon a time AT,
John,
looks compromised to me.
John, great case. It's amazing what you were able to do in such a short period of time. I think it looks like an excellent result, and obviously you got a little bit of stuff to do, but we're going to have to move on to our next live case in our next session. So appreciate it. Thank you so much, and we'll talk to you soon.
Okay, that was a wonderful and great demonstration. Can you just put up, as Dr. Rundback puts the TAC, Danny, can you just put up when Dr. Rundback just deploying the TAC as the panel gets on? So yeah, Dr. Rundback is deploying this TAC device. You're going to see it in a second. So this is a newer stent, which is basically more of a spot stent. It comes with 4 stents that you can deploy in one particular area. So you don't have to deploy all of them. You can actually spot the areas that you want to stent, or you can deploy all of them. So it's a very, very interesting device, and I'm sorry that we didn't have a lot of time to do it.